to have Dr. Wendy Post join us for our cardiovascular grand rounds. She's going to be presenting to us about cardiovascular disease risk in people living with HIV. Dr. Post is well known in our community. Dr. Post is a professor of medicine at the Johns Hopkins University School of Medicine and holds a joint appointment as a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Post is a cardiologist at the Johns Hopkins Center for Prevention of Cardiovascular Disease and the Echocardiographic Laboratory. She's also the associate faculty at Welch Center for Prevention, Epidemiology, and Clinical Research, and the director of cardiovascular research in the Division of Cardiology, and the director of research for the Hopkins Cardiovascular Fellowship Training Program. Dr. Post's research interests include prediction and prevention of coronary heart disease and certain cardiac death, non-invasive imaging of subclinical atherosclerosis, genetics of cardiovascular disease, and cardiovascular disease in HIV/AIDS. She's a principal investigator for the Hopkins Field Center for NIH-funded MESA study and for the Multicenter AIDS Cohort study, MACS, for cardiovascular disease sub-study. Thanks, Dr. Post, and we're looking forward to hearing from you.
Thanks, Dr. Kara, for that kind invitation. It's so nice to see so many familiar faces. I think I'm seeing Robert McNamara's face, which I haven't seen in quite a while. If this is the same Robert McNamara who trained at Hopkins years ago, right? Oh, you're on mute.
It is. Good to see you.
So nice to see you.
Yes.
So I'm just going to share my screen. Let's see here. Are you seeing the presentation mode and you see my cursor moving? You're on mute.
We're seeing the presenter mode. Yeah,
okay.
Swap displays.
It already is swapped? No, I have to swap?
Yes.
Okay.
Yep, perfect.
Okay.
Thank you.
Good morning. Thank you so much for having me today. I am, as Dr. Kara mentioned, a preventive cardiologist, but I spend most of my time doing research about prediction of cardiovascular disease, both in the general population and more recently trying to understand more about cardiovascular disease in HIV. So I'm going to start with a case presentation. This is a patient who was a participant in our cardiac MRI study that I'm going to tell you about. So she's a 42-year-old woman who's living with HIV, and she unfortunately has a history of polysubstance use, including heroin, cocaine, and alcohol. She has a history of medication non-adherence, smoking, tricuspid valve endocarditis, and coronary artery disease with a prior anterior STEMI with stents placed in the diagonal branch around 5 or 6 years ago. So as I'll tell you, part of our cardiac MRI study was to perform ZEO-patch. I'm sure many of you have familiarity with ambulatory blood pressure monitoring using a 14-day monitor. And so I was going through the reports, and then we send the reports to the participants, and I came across this one. And I was like, wow. So this patient had just routine ambulatory monitoring for our research study and had Torsades. And so, of course, we reached out to her, and she was essentially asymptomatic, and we attempted to get her into to care. So I'm going to talk a little bit about risk for cardiovascular disease in MRI and in people living with HIV through our MRI studies, EKG studies, and coronary CT angiography. So here's an example of what her cardiac MRI looked like. And you can see that her left ventricle is dilated. She has akinesis and thinning of the mid to distal anterior and anterolateral walls with a mildly decreased LV systolic function. Her EKG showed a QTC of 560, which is prolonged, and also a Q wave in V2 consistent with her prior MI. So the history of cardiovascular disease and HIV has changed over the recent decades with the institution of highly active antiretroviral therapy. People living with HIV now basically live a normal lifespan and have a chronic disease. So the proportion of deaths attributable to cardiovascular disease in the HIV infected population has gone up, even though it's going down in the general population, because now people living with HIV are living longer and getting diseases associated with longevity, but also associated with HIV. So this is a simple Venn diagram that shows general categories for why people living with HIV are at increased risk for cardiovascular disease, including a higher prevalence of traditional cardiovascular disease risk factors, especially smoking, a heightened inflammatory response to HIV infection, which may be due to both reservoirs of HIV infection that are still leading to replication of HIV virus, co-infection with other pathogens, and also microbial translocation from the gut. There are also known metabolic side effects of antiretroviral therapy, although this was really more of an issue in prior years when we used protease inhibitors that had significant metabolic side effects, but now the newer formulations of antiretroviral therapy have fewer side effects. So most of our work has been done in the multi-center AIDS cohort study, which is a prospective observational cohort study of the natural history of HIV in men who have sex with men. And we recruit participants from 4 sites in the United States, the Baltimore, Washington area, Chicago, LA, and Pittsburgh. So over 7,000 participants now have been seen since 1984. And the nice thing about this study is that it includes both HIV infected and uninfected men who have similar lifestyles since they're all MSM. So it leads to a nice sort of comparison group for observational analyses. Participants are seen every 6 months with standardized interviews, clinical evaluation, and laboratory tests. And then in recent years, the MAX combined with the WISE, which is the Women's Interagency Health Study, in order to have a cohort of both men and women. So now it's called the MAX-WISE Combined Cohort Study. So back in 2008, I got a R01 grant to perform coronary CT angiography. So it was kind of an interesting time. It's hard for the younger people in the audience to remember that time, but coronary CT angiography was just starting to be used clinically and really hadn't been performed in sort of a general population that didn't have known cardiovascular disease. There were a lot of questions back then about whether people living with HIV truly had an increased risk for cardiovascular disease, or whether the studies that were coming out suggesting this increased risk were confounded by other lifestyle factors. So we thought we had a really good design for a study in order to look at subclinical coronary atherosclerosis. So we proposed to look at the prevalence and extent of subclinical atherosclerosis and coronary CT angiography, comparing HIV infected with uninfected men, and to determine potential mechanisms leading to subclinical atherosclerosis in this population. So we included active MAX participants between the ages of 40 and 70. We excluded people with a history of cardiac surgery or prior coronary interventions due to the inability to analyze those segments of the coronary tree with CT angiography, and severely obese individuals due to limitations of CT. We performed non-contrast CT scans on everybody, and coronary CT angiography in those without exclusions due to low eGFR or contrast allergy. So as most people in this audience know, with coronary CT angiography, we can get an assessment not only of coronary stenosis, but also the composition of plaque. And so plaque was characterized as non-calcified plaque, mixed plaque, or calcified plaque from the reading center that Matt Budoff leads at Harbor UCLA, now called the Lundquist Institute. So these results were published in 2014, where we found an association between HIV infection and subclinical atherosclerosis. Specifically, we found that men living with HIV had a 13% greater prevalence of having any plaque, 25% greater prevalence of non-calcified plaque, and a borderline significant higher prevalence of mixed plaque. And this was after adjusting for demographics and a variety of cardiovascular disease risk factors. We also looked at predictors of coronary artery stenosis greater than 50%. and found that having a low nadir CD4 T cell count and duration of highly active antiretroviral therapy were both associated with the likelihood of having a significant coronary artery stenosis. So this low nadir CD4 cell count suggests that people who had more severe longstanding, as marked by duration of heart, longstanding and severe immunodeficiency were at increased risk for coronary atherosclerosis. Since that time, we've done a number of analyses using these data to try to understand more about risk prediction and also about mechanisms that might lead to increased risk for coronary atherosclerosis in people living with HIV. This is an analysis using the pooled cohort equation that was performed by Anne Monroe. And this analysis compared the AUC, or the ability to discriminate the likelihood of having either coronary artery calcium or coronary stenosis in men living with HIV or in HIV uninfected individuals. And here you can see in the lighter gray, the AUC, the ROC curve for the men living here is without HIV uninfected, and the darker black is the men living with HIV. So what you see is that the pooled cohort equation is able to discriminate the likelihood of having coronary artery calcium better in HIV uninfected than HIV infected individuals, and the same thing for coronary stenosis. So what this suggests is that our traditional cardiovascular disease risk factors, as reflected by the pooled cohort equation, predict risk better in the general population than in people living with HIV. More recently, we've been looking at the polygenic risk score. So many here also are probably familiar with this groundbreaking paper by Amit Khera. This is the Amit Khera at MGH, not to be confused with the Amit Khera from UT Southwestern, who has the same name. Amit Khera and his group developed a polygenic risk score with over 6 million common variants across the genome, and was able to show that higher polygenic risk scores are strongly associated with the prevalence of coronary artery disease. Here in this population, those in the greatest 0.5% of the polygenic risk score have a 5-fold greater likelihood of being, or odds of being, of having had coronary artery disease. Here you can show the polygenic risk score percentiles associated with cases of coronary disease versus control. And the greater the percentile of the polygenic risk score, the greater the prevalence of coronary artery disease. So clearly a very strong predictor of risk in the general population. So what we did, working with Jen Wojcik and Priya Dugal at Hopkins, is we looked at the polygenic risk score in our population of HIV infected and uninfected individuals. So we used this genome-wide polygenic risk score, and we looked at associations with coronary artery calcium from our non-contrast CT scans, and categorized people as having no coronary calcium, low or high coronary calcium scores based on a score greater than 100. So here you can see that same area under the ROC curve that I was showing you for the pooled cohort equation, but here it's based on the polygenic risk score. These are only European American participants, since the polygenic risk score is derived from a cohort of Europeans, and so it doesn't perform as well as in African Americans. We also perform similar analyses in African Americans and don't show this difference. But here you can see again that the area under the ROC curve for people living with HIV was less than it was for the HIV uninfected individuals, again suggesting that not only are traditional cardiovascular disease risk factors not as strongly as associated with coronary calcium, but also this genetic risk score, which of course was developed based in a general population and not based on an HIV infected population. We also showed that this difference was greater in Agatston score greater than 100 versus 0 relative to these analyses of mild coronary calcium versus 0. So this disparity widens at the extremes of coronary artery calcium. So I guess the question then would be, what is the missing factor here? So we know that polygenic risk scores work really well in the general population, and we know that the pooled cohort equation, of course, predicts risk in the general population as well. So why doesn't it work as well in people living with HIV? So before I tell you what I think the answer is, just thought maybe we take a little break and use this cartoon, which I love, which shows physician saying, you're 57 years old, I'd like to get that down a bit. So of course, we know that age is the strongest risk factor for coronary artery disease. And so if we could all figure out how to modify that, we'd be very successful physician scientists. But I think the part that is missing in the people living with HIV in terms of being able to predict risk is inflammation and immune activation. So this is a nice, pretty picture, of course, showing the coronary endothelium and the importance of inflammation leading to plaque rupture and thrombus formation in the etiology of coronary artery disease. And of course, in this audience, you know that the CANTOS study with Paul Ricker's group proved the inflammation hypothesis. If you suppress inflammation with canakinumab, you reduce risk for MACE by 15%. And so again, emphasizing the importance of inflammation as a specific factor that increases risk for coronary disease in the general population, which of course is not included in our pooled cohort equation. So there have been a number of studies in people living with HIV to assess the importance of HIV viremia on risk for cardiovascular disease. This one was called the SMART study. And in this study, the over 5,000 HIV infected patients with CD4 cell count greater than 350 were randomized to treatment interruption with antiretroviral therapy versus continuous treatment. So at that time, you know, back here in, this was published in 2006, the question was, we know that antiretroviral therapy has potential side effects, metabolic side effects. Maybe it's actually increasing risk for adverse outcomes. And so if we use treatment interruption and only treat with antiretroviral therapy when the CD4 cell count is low, maybe we'll actually reduce risk. But the result of the study was the opposite. So treatment interruption was associated with an increased risk for major cardiovascular, renal, or hepatic disease compared with continuous treatment. And here you can see that the fatal or non-fatal cardiovascular disease events were increased by 60% with a borderline significant p-value, again, suggesting that the inflammatory response to the virus, when it's not suppressed by antiretroviral therapy, significantly increases risk for cardiovascular disease in addition to other adverse outcomes in people living with HIV. So since that time, recommendations for antiretroviral therapy, of course, have changed in that people now are started on antiretroviral therapy essentially as soon as they're diagnosed as having HIV in order to suppress viral replication and try to inhibit this inflammatory response and immune activation that we think is potentially leading to increased risk for cardiovascular disease in addition to a number of other disorders. So here we looked at, again, our multicenter AIDS cohort study, and most of the participants in the MAX are actually virally suppressed. So they have undetectable viral load. So we talked about how untreated HIV can lead to inflammation and immune activation, but we actually know that even among people with undetectable viral load due to effective antiretroviral therapy, there are still higher levels of immune activation and inflammation, as I mentioned earlier, potentially due to HIV reservoirs, due to co-infections, or due to microbial translocation in the gut. So here we did a study of monocyte activation markers that were measured at the time of cardiac CT scanning. And this was a study I did with Becky McKibben. And we were able to demonstrate, as others have, that or HIV infected men had higher levels of these monocyte activation markers in the blood than the HIV uninfected individuals, even though they had viral suppression. So monocyte activation markers were associated with T cell counts, with nadir T cell counts, again, with HIV RNA, whether it was detectable or not, and the percent of visits with detectable HIV RNA. So it's important to try to suppress the HIV viremia in order to limit the monocyte activation markers and other measures of inflammation. And then Becky was able to show that people living with HIV who have higher levels of soluble CD163, which is a monocyte activation marker, have higher levels of coronary artery calcium and also more likely to have stenosis greater than 50% or have plaque present. And this is after adjusting for demographics and cardiovascular disease risk factors. And similar study was done by Hossein Barami in our group, looking at quartiles of inflammatory markers you may be more familiar with, such as IL-6 and TNF alpha receptor 2, showing both in HIV infected and uninfected individuals that higher levels of these inflammatory markers are associated with a greater prevalence of coronary artery stenosis. So I mentioned co-infections. So at the time, people were living with chronic hepatitis C virus because we didn't have effective treatments like we do now. So we looked at chronic hepatitis C virus in our population and the likelihood of having coronary plaque. And since this is an MSN population and not necessarily an injection drug use population, the prevalence of chronic hepatitis C was relatively low, but we were able to demonstrate that the people who had chronic hepatitis C virus had a greater prevalence, again, of coronary calcium, any plaque on CT angiography, and also non-calcified plaque. And that's, again, after adjusting for cardiovascular disease risk factors and demographics. And this was in a model that also adjusted for HIV, since people living with HIV were more likely to have chronic hepatitis C virus, but the HIV effect and the chronic hepatitis C virus effect were independent of each other, suggesting that if you have both HIV and chronic hepatitis C, that those risk factors would be additive in terms of increasing potential risk for cardiovascular disease. And trying to understand more about mechanism, similar to viral loads for HIV, we looked at the RNA levels for hepatitis C virus, and the men with the highest levels of hepatitis C RNA here, greater than 2 × 10⁶, had an increased risk for coronary atherosclerosis, but those who had lower levels of hepatitis C virus in the blood were not at higher risk. So again, suggesting that this viral replication, in this case hepatitis C, was potentially fueling risk for subclinical atherosclerosis in this population. So that was what we called CVD2. CVD1 was a study which was only coronary artery calcium and carotid atherosclerosis. CVD2 added coronary CT angiography. And then CVD3 was a study, or is a study, where we looked at progression of coronary artery stenosis. So not only did we have this huge observational study of coronary CT angiography with over 760 men getting CT angiography, here we repeated CT angiography in those same men, trying to understand whether coronary artery stenosis progresses more rapidly in HIV infected than uninfected men, and does HIV viremia predict progression of coronary stenosis. So this is an example of a baseline CT angiography with this LAD having no evidence of coronary atherosclerosis. And here we are 5 years later, and you can see that this individual has developed some focal calcification in the LAD, although clearly subclinical and not leading to significant stenosis. So we evaluated whether coronary artery stenosis progression was associated with HIV serostatus, and also whether it was associated with suppression of viremia. So those of you who take care of HIV infected individuals know that there's this concept called a blip. So every once in a while, in someone who is suppressed, where all their blood tests show no detectable viral load, occasionally you'll get a little blip where there's this low level of HIV viremia. And that's felt to really not be significant as long as it's not persistent. So we defined HIV suppression as consistently suppressed viral load between the two scans, which were on average 4.5 years apart, or suppressed with a single viral load blip. And we looked at stenosis progression in each individual segment. In each segment, stenosis was categorized as being minimal, mild, moderate, or severe. And so we defined progression as progressing from one category to two categories more. So either having no plaque and then mild, or less than 30 to greater than 50, et cetera. So at least two categories of progression in an individual segment during the interscan interval. And what we found is that people with HIV who were viremic had a 2.5-fold greater risk of coronary artery stenosis progression compared with the HIV uninfected individuals. Whereas if you're living with HIV and suppressed, which most of the individuals in this study were, then there was no increased risk for coronary stenosis. Again, suggesting that viremia is the fueling mechanism for coronary artery stenosis progression in people living with HIV after adjusting for cardiovascular disease risk factors, which of course are important in this population as well. So here's the multivariable model, and you can see, as you would imagine, that cigarette smoking and traditional cardiovascular risk factors such as lipids were associated also with progression. Then we looked at the more granular level of HIV viremia. So we separated out those who had consistently suppressed viral load from those who had a single blip, people who had multiple blips, again, this low level viremia, and people who had significantly elevated viral load, greater than 500 copies per ml. So graded increase in degree of viremia during the interscan interval. And what we were able to show is that the more viremia that was present during that interscan interval, the greater the risk for developing coronary artery stenosis progression. So the greatest risk, of course, were in those who had at least one viral load greater than 500 during the interscan interval. And there was this nice graded relationship between extent of viremia and risk for coronary artery stenosis progression. So we concluded that progression of coronary artery stenosis assessed by coronary CTA is associated with presence of HIV viremia and traditional cardiovascular disease risk factors. An effective ongoing HIV virologic suppression is needed as it may mitigate increased risk for coronary disease among people living with HIV, but additional studies are needed to ascertain the significance of viral blips and risk for cardiovascular disease. So I'm now going to change the outcome measure here. So I think I showed you data that convincingly shows that people living with HIV are at increased risk for coronary atherosclerosis, most likely due to immune activation and inflammation, and also with traditional cardiovascular disease risk factors. But there also have been reports suggesting that people living with HIV are at increased risk for sudden cardiac arrest. There have also been some reports suggesting people living with HIV may have abnormal ventricular repolarization. So we looked at QT interval and inflammatory markers in the multicenter AIDS cohort study using routine electrocardiograms. And we were able to demonstrate that the people living with HIV had a longer QT interval, 4.4 milliseconds relative to the uninfected individuals after adjusting for a variety of different associations or confounders with QT, including demographics, use of opioid medications and cardiovascular disease risk factors and use of QT prolonging drugs, suggesting that potentially people living with HIV may be at an increased risk for sudden cardiac arrest or ventricular arrhythmias, like that poor young woman who's presented with essentially asymptomatic torsade that I showed you at the beginning. And when we looked at levels of inflammatory markers, we were able to demonstrate that these levels of inflammatory markers were also, associated with the QT interval, such that higher levels of IL-6 were associated with longer QT intervals, suggesting that inflammation may also affect ventricular repolarization. And when we included these inflammatory markers in our multivariable model, the mean difference in QT interval, adjusted QT interval between HIV infected and uninfected individuals was lower, suggesting that these inflammation markers contributed to the QT prolongation that we saw in people living with HIV. Then we performed, as I mentioned, ambulatory EKG monitoring. And so this is a patch monitor that's worn for 14 days and can detect atrial and ventricular arrhythmias. We calculated what's called the QT Variability Index, which is a measure of the variability in the QT interval relative to heart rate variability. So this is a measure that was developed by Ron Berger, who's the director of our EP fellowship program at Hopkins, and has been associated with risk for ventricular arrhythmias. So you probably know that heart rate variability is generally greater in people who are healthy. So decreased heart rate variability is associated with disease, but QT interval variability is actually the opposite. So healthy people generally have low QT variability, whereas people who have coronary disease have greater variability in the QT interval from beat to beat. And it's suggested that this variability in QT interval may contribute to risk for ventricular arrhythmias. So Amir Haravi worked on this study. It was a lot of work. We basically took the original EKG tracings from the Zeo patch and had to clean them manually to take out long periods with either no or low quality data. And then we used this automated algorithm that had been developed by Ron Berger's team to analyze the EKG tracings beat to beat. We calculated this QT variability index over 5-minute intervals throughout the up to 14 days of monitoring. We also were able to break the code for an accelerometer, which is present within the Zeo patch as well, which we then developed an algorithm to determine whether participants were standing or supine or recumbent, presumably sleeping, since QT variability is also related to position. And so we adjusted for that as well. So we did a multivariable model. We adjusted for a variety of risk factors for QT variability, including demographics, opioid use, QT prolonging drugs, cardiovascular disease risk factors, and as I mentioned, body position. So what Amir Haravi was able to demonstrate is that the people living with HIV had greater variability in their QT interval. And we then looked at, again, whether variability was related to viral load. And we could see that people with detectable viral load had greater QT variability than people with undetectable viral load. And then among those with detectable viral load, the extent of viremia was also associated with QT variability. There were a variety of other traditional risk factors associated with QT variability. So this suggests that all these factors are additive. So if someone's living with HIV and they smoke, as our case participant did, and if they also have diabetes, then all of these things additively increase the likelihood that they have greater QT variability, which might increase the risk for cardiac arrest and ventricular arrhythmias. Again, we looked at measures of inflammation in the blood, and we're also able to show that a variety of markers of inflammation were also associated with QT variability. And as I mentioned previously, these markers are elevated in people living with HIV, even among those who have undetectable viral load. So we had ambulatory EKG from over 1,000 men with no history of cardiovascular disease. So this was the largest study that we know of QT dynamicity variability, with many hours of ECG analyzed in B2B variability, which is a marker of labile ventricular repolarization. We found that higher QT variability was associated with HIV, progressively associated with viral load, and this effect was independent of other cardiovascular disease risk factors. We found inflammation was associated with higher ventricular repolarization variability, and proposed that this increased repolarization instability could be a potential mechanism linking HIV to cardiac arrhythmias and increased risk for sudden cardiac death. I'm now going to quickly transition to our other outcome, which has been cardiac MRI. So this is a study that I've been working on with Dr. Kathy Wu, who's a cardiologist who specializes in cardiac MRI with me at Hopkins. So this is the Subclinical Myocardial Abnormalities in HIV study. So this is a general background slide demonstrating why people living with HIV may be at increased risk for heart failure. So the same kind of risk factors we've talked about before, in addition to general mechanisms for myocardial injury, may predispose to pre-heart failure phenotypes, which is what we evaluated with cardiac MRI, including systolic dysfunction, impaired relaxation, ischemic and non-ischemic scar, or myocardial fibrosis, which may all increase the risk for heart failure. So observational studies have demonstrated that people living with HIV are at increased risk for both HFrEF and, importantly, also HFpEF, or heart failure with preserved ejection fraction. So we were looking to identify mechanisms for increased risk for heart failure in people living with HIV, but we also importantly wanted to determine if substance use was also contributing to this increased risk. So we felt that, some of the observational studies may have been confounded by the higher prevalence of substance use in people living with HIV, which could also increase the risk for myocardial disease. So we included a cohort of over 400 people who were demographically balanced and representative sample from 3 longstanding longitudinal cohort studies of people living with HIV and people without HIV. So the MAX, which I've been telling you about, the Women's Interagency Health Study I mentioned, is a similar study of women with and without HIV. And the ALIVE study is a study in Baltimore, including injection drug users with and without HIV. So we recruited individuals who lived in Baltimore and Washington from either of these studies, and we measured we performed cardiac MRI. We measured the typical things, LV and RV mass and volume, systolic function, strain, diastolic function, and also left atrial volume, strain, and strain weights. You've probably heard a lot about myocardial late gadolinium enhancement from the recent studies about myocarditis and associated with the COVID pandemic and the COVID vaccine. But here's an example of late gadolinium enhancement or myocardial scar in an ischemic pattern or a non-ischemic pattern. So what we were especially interested in is this non-ischemic pattern where the late gadolinium enhancement is epicardial or mid-wall, which is not consistent with coronary artery disease. We also did T1 mapping and extracellular volume measurements, which is a way to measure kind of diffuse interstitial fibrosis. And we were able to demonstrate that HIV infection was related to differences in interstitial fibrosis and left atrial size. So we found that the men and women living with HIV had higher left atrial volume index. They also have greater prevalence of subepicardial scar, which is non-ischemic scar, greater extracellular volume, and greater T1 measures. So here are some examples of focal myocardial scar in our study, where you can see that the scar is mid-wall or subepicardial, which is non-ischemic scar. And then we had a few people with ischemic scar, presumably from prior coronary artery disease. So we found, after adjusting for demographics and cardiovascular risk factors, that the people living with HIV had larger left atrial volume, greater subepicardial non-ischemic scar, and higher ECV, suggesting increased diffuse fibrosis. Of course, all this can increase the risk for potentially for heart failure with preserved function, so HFpEF, preserved ejection fraction. So we concluded that they had essentially normal left ventricles. We found very few people with low ejection fractions, whereas some of the older cardiologists in the audience will remember when prior to effective antiretroviral therapy, these mostly young men were dying of horrible dilated cardiomyopathies, which essentially is non-existent now that people are taking effective antiretroviral therapy. So we didn't find LV systolic dysfunction, but we found a very low prevalence of ischemic scar in this population, but we found a greater prevalence of subepicardial non-ischemic scar, which may have adverse prognostic implications, greater ECV, extracellular volume, which denotes increased interstitial fibrosis, which was not explained by HIV disease risk factors or substance use. We found greater left atrial volumes, not explained by HIV disease severity or substance use. And all of this could portend increased predisposition to clinical heart failure and atrial arrhythmias. So now we're looking at biomarkers in order to try to understand potential mechanisms leading to these subclinical abnormalities, which may potentially lead to increased risk for HFpEF in people living with HIV. So going back to our patient, we sort of had a whirlwind tour of various potential mechanisms where this poor young woman may be at increased risk for sudden cardiac death. We talked about her prolonged QTc, which is associated with HIV, her polysubstance use, which we know is also associated with QT prolongation, medication non-adherence, so she's not taking her HIV antiretroviral therapy, so she presumably has uncontrolled viremia leading to inflammation and immune activation. Of course, smoking is a very strong risk factor for cardiovascular disease. You know, she has a history of tricuspid valve endocarditis, and she also has a history of an anterior MI. I showed you how her cardiac MRI showed that she had a dilated LV with prior coronary artery disease manifesting as anterior and anterolateral wall akinesis and thinning with mild low ejection fraction. So, you know, I think we can now understand why this woman is at increased risk and try to figure out ways that we can reduce risk for cardiovascular disease now that the population living with HIV is aging and presenting with chronic conditions more like coronary artery disease. So in summary, I think I showed you that HIV is associated with an increased risk for coronary artery disease, which may be due to immune activation. Heightened inflammatory response likely contributes to this risk. Virologic suppression reduces but does not normalize systemic inflammation. We briefly talked about the CANTOS study using canakinumab in the general population, which proved that IL-1 beta blocker reduces cardiovascular disease, proving the inflammation hypothesis to atherosclerosis. There are preliminary studies ongoing in people living with HIV trying to reduce risk for cardiovascular disease or subclinical cardiovascular disease using low-dose methotrexate, colchicine, also using canakinumab or PCSK9 inhibitors, with the hope that we can reduce risk by reducing inflammation in this population. We also showed that HIV is associated with left atrial enlargement and ventricular fibrosis, which may predispose to increased risk for HFpEF. So clearly, additional research is needed to inform HIV cardiovascular disease prevention guidelines and recommendations. I didn't show you these data, but there's a very large randomized trial ongoing called REPRIEVE, which is led by Steve Grinspoon at Harvard. And that's testing whether statin therapy with pitavastatin, which is less likely to interact with antiretroviral therapy, reduces risk for cardiovascular events in people living with HIV who don't have clear indications for statin therapy. So it may be that using statin therapy in people with HIV and normal lipids may help to reduce risk. And of course, HIV is listed as a risk enhancing factor in the cardiovascular disease statin therapy recommendations. So we know that current cardiovascular disease risk scores are imperfect. There are some HIV specific risk scores that have been developed, and I didn't show those data, but they didn't work very well either. So we need additional HIV specific risk variables included in our risk scores in order to more accurately predict risk for cardiovascular disease, to identify people at greatest risk who deserve our most potent prevention strategies. But generally, until guidelines are in place differently, we generally follow the HAACC guidelines, and we treat people living with HIV who have multiple cardiovascular risk factors most aggressively. So of course, all of this work is the work of multiple people. And so want to acknowledge my co-investigators from Hopkins, from the Multicenter AIDS Cohort study in Baltimore, Chicago, the Data Coordinating Center, from the Women's Interagency Health study in Georgetown, the ALIVE study, and then multiple people who contributed to the coronary CT angiography studies. Thank you very much.
Thank you so much. That's such an excellent talk. We have a series of questions. I see two hands up, Dr. Zared and Dr. Amani, and I'll let them ask their questions, and then we have comments in the chat as well.
Oh, you're on mute. Okay.
Should I start? Yeah, thank you for a wonderful talk. I'm wondering if there are any data, or if you care to speculate, as to whether there are viral effects on the development of coronary atherosclerosis independent of inflammation. And
you
then
mean direct viral effects.
Right, direct viral effects that can lead to coronary arteriosclerosis, not due to the traditional associated inflammatory reaction. And in that light, are there any data comparing relative coronary risk between HIV patients and patients with other more pure inflammatory diseases, such as inflammatory bowel disease and rheumatoid arthritis, that might suggest that also that there might be a viral effect that's independent?
Yeah, thank you for that really important and interesting question. There is evidence that HIV virus is seen in the myocardium. I don't know if it's actually seen in atherosclerotic plaque. There are some data to suggest that there might be direct viral effects, but I think that is largely speculative, and I'm not sure that there is real convincing evidence for it. But it, of course, is a really important question. In terms of comparing to other inflammatory conditions, so, you know, just like we learned over the last 10 to 15 years of the importance of inflammation in HIV, we know that other rheumatologic disorders like rheumatoid arthritis is associated with increased risk for atherosclerosis and cardiovascular disease as well. I haven't seen direct comparisons, which maybe, as you're suggesting, might get at this question of whether HIV virus infection directly is causing atherosclerosis. You know, some of those studies might be confounded by differences in the population because people who have HIV have a risk factor for getting HIV, so they tend to be different than people who have rheumatologic disorders. So it would be an interesting study design and an interesting way to answer that question, but might be hard to really adjust for all the confounding factors. But that's a really important point, and I thank you for the question.
Thank you.
Very intriguing talk and very interesting talk, and thank you very much for so much information. You actually showed that there is no direct correlation between myocardial disease, viral load, antiviral therapy. But I wonder, actually, given this is a retrovirus that can incorporate itself in the DNA, if it doesn't disrupt actually several genes, gene function, and if you have looked at methods such as, looking at the RNA-seq of the myocardium, or even looking at the whole genome sequencing, et cetera, to come up with novel risk factor, because probably retrovirus, you don't have to have any more virus present. It already incorporates itself in the DNA, and the damage is done, and maybe that's where we have to look.
Yeah, and that's an interesting question. I haven't seen any data about that. There are all these data about these reservoirs where HIV hides and is replicating but can't be detected. But I haven't heard much about actually looking for the retroviruses in the DNA of HIV infected individuals. But it's an interesting question.
I had a question.
Sorry, go ahead.
Back in 1996, we identified a increased incidence of long QT amongst the HIV population, and actually performed stellate ganglion block and beta challenge, and didn't see a suppression or change in the long QT, and suggested that these patients had some form of an acquired long QT syndrome, but didn't know the mechanism. But interestingly, these were treated with mixilotine, and that suppressed the arrhythmia. One patient had an allergic reaction to mixilotine. It was stopped, and again, a year later, developed torsade. And so I'm wondering whether you've explored any direct effect on sodium channels related to HIV.
Yeah, thanks for that question. And I guess it's interesting to think back to 1996 when our patients were, not necessarily effectively treated with antiretroviral therapy. So there would be more inflammation, and wonder whether, we were able to determine how much inflammation those patients you saw had. There may be some data about sodium channels and the effect of HIV viruses. You guys are all asking me these basic science questions, and I'm an epidemiologist. But I really just don't know all the details about that. But maybe you do, since you asked the question. Do you know if there is? You're on.
No, I haven't seen the literature, but I just sort of think it might be interesting to look at, and you have all this data.
Yeah, exactly.
Okay, we have 3 questions in the chat. So first is O'Leary. How can we apply the learnings from HIV and CAD inflammation studies to predicting or understanding CAD risk in COVID?
In COVID, yeah. So there's a lot of unknowns about risk in COVID in the long term. And so you mentioned in the introduction that I'm the PI of the Hopkins Field Center for MESA. So we're participating in C4R, which is the collaborative cohort of cohorts, where we're combining all these NHLBI observational cohort studies in order to develop a very large database of variables that existed prior to COVID infection, and to see how they changed over time. Most of the studies we're looking at just look at people who have been infected with COVID, and you don't really know what they looked like before. So we have cardiac MRIs, we have EKGs, we have biomarkers. And so we're planning to look at what predicts what's called PASC now, post-acute sequelae of COVID, or long COVID, or long haulers by the general population nomenclature. And some of it may be persistent inflammation. I think it's probably multifactorial. And, there's so many different presentations of both acute COVID cardiovascular events and also this long COVID or PASC. different presentations in terms of symptoms and signs, and then potentially different mechanisms that we'll learn more about. But I think what you're getting at is that, clearly inflammation is key. And we know that the unchecked immune activation and inflammation that occurs, maybe 7 days after infection is clearly leading to the really severe acute cases of COVID and people who are dying, even though they're getting appropriate support. So, inflammation and unchecked sort of hyper response to the virus is clearly related, and whether that's causing, myocarditis, which we've seen, and very few cases of actually type 1 MIs where there's plaque rupture and thrombus formation, but more likely type 2 MIs and people dying of ventricular arrhythmias. So lots of things to learn, but I guess you can say maybe we've learned a little bit about this risk from the studies in HIV.
Thank you. Eric, do you want to ask a question yourself? I see you there.
Not sure my microphone works. Do you hear me?
Yes.
Okay. Hey, Wendy, thank you so much. Impressive work and really exciting to see how this is played out over time. My question is quite simple and clinical, I guess, based. From what you've learned, would you recommend baseline or repeat cardiovascular imaging in persons living with HIV who have not achieved viral suppression? Because it is, in these cases, the one you shared with us is still, unfortunately, can be common in some populations. I'm just curious how you approach patients clinically around this.
So the question, it's a little hard to hear, was whether we would recommend cardiovascular imaging in people who don't have viral suppression. And unfortunately, you in New Haven and we in Baltimore see a number of these patients. So, I would say probably not, because I'm not sure it would change our management. So if somebody is not virally suppressed, then there are obviously social determinants of health that are limiting them getting effective therapy. I would concentrate my efforts there, which clearly aren't easy, but that's really what they need, is they need to get their virus suppressed. Of course, I would treat all their cardiovascular disease risk factors aggressively, but I'm not sure imaging would change my management, sort of like in the general population, when do you do a stress test or a CT angiography? I'm not sure I would do that in someone who's asymptomatic, so it doesn't really change my management. But I think the point of your question is just emphasizing how important it is for us to, think about cardiovascular risk in these patients who unfortunately, fall through the system in whatever way and don't get appropriate therapy for their HIV. They're probably not getting appropriate therapy for their cardiovascular risk as well. And, they need a lot of attention, and sometimes it can be very challenging.
Thank you. So we have Erica and then Jeff. So Erica's question was, fantastic talk. Could you say more about the viral blip? Is that a sign of lingering virus, decreased immune system, or adherence?
Yeah, that's a good question. And it's not completely known what it's from, but it's probably multifactorial, the things that you mentioned. So it could be adherence, whether, those of us who take medications know sometimes you just forget to take it. So did that lead to a blip in someone who's usually suppressed? Is it some measurement error? Is it some, intermittent release from these viral reservoirs that goes unchecked? It's really not that clear what exactly causes it, but generally the HIV physicians just ignore it. And so what we were trying to point out with our study is that it seems to be in this stepwise relationship with risk for coronary stenosis. It seems the blips may actually mean something, and maybe we should be paying more attention to them.
Perfect. Jeff, do you want to ask your question?
Sure. Wendy, thanks for joining us today, and that's absolutely terrific work. You've already deflected the basic science questions, so I won't ask you details of this, but staying on the inflammation theme, I wonder if there's a sort of, for lack of a better term, a class effect of retroviruses in this regard. I think if there is, if similar patterns, pathologic patterns, QT prolongation, et cetera, are seen in the context of other retroviruses, it actually may give us some clues about the inflammatory pathways that are activated, because they would lead to different therapeutic targets. So it's one thing to say, we should use canakinumab and IL-1 antagonists, whatever, but there could be a lot more specific targeting that could be helpful. So do you know if lentiviruses, other retroviruses that, as Arya said, get, reverse transcribed and integrated into the genome, do you know if they cause similar types of alterations?
Yeah, thanks for that interesting question. I don't know how prevalent those viral infections are, and I don't know if there have been studies that have looked at that. But I think what you're getting at is that there are multiple ways to treat inflammation, and we were all very impressed with canakinumab, which is inhibiting IL-1 beta from the inflammasome. But then we heard the results of the methotrexate study, and unfortunately didn't see any reduced risk for cardiovascular disease, even though methotrexate is, clearly effective in treating rheumatologic disorders. It didn't lower CRP from what I remember, but I guess it just kind of emphasized to us that all inflammation is not the same. And so canakinumab may be effective. And I think what you're getting at is that, maybe HIV is leading to a specific form of inflammation that needs to be treated in a specific way. And what do we know about retroviruses versus, HIV versus other retroviruses, and how do we effectively treat inflammation to reduce risk for cardiovascular disease? Then that all forms of anti-inflammatory therapies are not the same, which was kind of, surprising to me, maybe not to you, but it would have been nice if just lowering inflammation, whatever way we did, would reduce risk for cardiovascular disease. But clearly we have a lot more to learn about how each individual inflammatory disorder may be triggering an immune response or an inflammatory response, and maybe we can't treat them all the same way. So maybe you know more about that, although I see it's 9:02. So, but thank you for that interesting question.
But thanks, Dr. Post, again for taking the time this morning to meet with us and answer all our questions. And we appreciate it, and we look forward to hosting you in person in the future. Thank you.
Yeah, great. Thank you so much.
Bye. Thanks, everyone.